I'm gonna start recording. Yep. And then this will be open throughout the meeting. So please give us your thoughts because we really do look at every single comment and put them together into an agenda. And that's what we'll share what that agenda is for 2025 in our very first meeting. And you can plan then to attend each of the meetings accordingly. So we ground ourselves in data. And so with that, always excited to introduce Amy Marsman, our senior research analyst at OCMH, and she is going to share data information related to the youth crisis system in Wisconsin.
Thank you, Karen. Can you hear me okay?
Yes.
Okay, great. Thank you. Good morning, everybody. I am going to provide a quick overview of some key mental health data, and hopefully we'll have a minute or so for questions. If anything comes up, please let me know. I'm not going to have my eye on the chat, but my colleagues will help me out in that regard. So I want to start just with the overview of the the whole population of Wisconsin youth. What we're looking here on the screen at is a key facts document that we created. And these are trends that are almost primarily based on YRBS data, which is the Youth Risk Behavior Survey. YRBS is a survey that's given to high school students every 2 years, and they use a sampling from among Wisconsin's 2,300 schools. Um, so it's a long running survey that is also coordinated through CDC, and many states do it, almost all states. So we can look at how Wisconsin is doing over time and look at long-term trends, which we're really looking at 10-year trends as much as we can this year. And we can also compare to the the nation as a whole. So what we see here, if you can go to the next slide, Karen, is that we see that mental health concerns are rising, and they have been for the last 10 years. You've probably heard us say this before. The youth mental health crisis did not start with COVID, but COVID certainly seems to have made things worse. Um, but really, what we're seeing in the most recent YRBS data is that half of high school students reported anxiety at 52%. Over a third reported being sad or hopeless every day consistently, which is a marker for depression. Um, Only a quarter of high school students get sufficient sleep. And that's really important because sleep is just critical to mental health. And we're seeing those sleep rates decline. We also saw that a quarter of Wisconsin girls seriously considered suicide last year. And a fifth of students, 21%, reported self-harm in the last year. And on the right, what we're seeing is measure of school belonging, how connected students feel to their school. And this is a pretty steep decline over the 10 years from 2013 to 2023. The rate of students feeling that they belong in their schools has dropped to about half. So at this point, half of students in Wisconsin feel that they do belong, and the other half approximately feel they don't belong. But those numbers are varied by student group. So we'll get into that a little bit in a minute. The next slide just shows those percentages. If we were to extrapolate out the number of kids that this is impacting, we have about 800,000 students K-12 in Wisconsin. If we were to extrapolate this out to the whole student population, we would be looking at dealing with 400,000 kids who are experiencing anxiety. 280,000 are experiencing symptoms of depression. 208,000 are getting sufficient sleep. So 600,000 are not. And 92,000 girls would have seriously considered suicide. 168,000 kids would have reported self-harm. So these are extrapolated numbers, but I think it's helpful in conveying the magnitude of what's happening. Here is where we see some of those key markers by student group. Um, so we see that the fact that mental health is an issue for most kids is really borne out in the YRBS data. We know that last year, 6 out of 10 high school students reported at least one mental health concern. So we know the majority of teens are struggling with something, but mental health is disproportionately affecting some student groups more than others. And what the data is showing us here is that marginalized students are suffering higher rates of mental health problems, especially girls and especially LGBT kids. And that's not new either, but in depending on the indicator, kids of color are also more susceptible to having a mental health problem. On the next slide, we're going to zero in on some of the more serious mental health problems and take a look at kids who are in crisis. This is another document that we produced, and I'll walk through each of these graphs so you don't have to strain your eyes. On the next slide, we're going to look at clinical levels of mental health problems. On the left, we have major depressive episodes. This is displayed on the left. And we see that for youth and young adults ages 12 to 25, they suffer from major depressive episodes at a much greater rate than the adult population does. So it's 2.5 times more than adults who are 26 and older. Um, on the right, we have young adult mental illness. Here we see that there's been a substantial increase in the rate of young adults who are ages 18 to 25 with a diagnosed mental illness. There was a 42% increase in this 5-year period between 2017 and 2021. So those are not self-reported on the YRBS. Those stats and the ones that are on the screen, sorry, the stats that were on the last slide um, are not self-reported by students. These are collected through a different survey, and they are clinically diagnosed. Looking back at the high school students again from the YRBS, we see over the 10-year period of 2013 to 2023 that there was a similar increase, 41% increase in teens who seriously considered suicide and a 45% increase in teens who actually attempted suicide. And if we were to look at what that means in terms of numbers, that would be roughly 5,655 students who had attempted suicide. Data from the DHS, the Department of Health Services, self-harm and suicide dashboards. On the next slide, it will show us that there were 1,650 youth who went to the emergency department or the ER for self-harm. The methods of self-harm are usually drug overdose or cutting, and by far, most self-harming is done by girls. And that's what we see on the left. That pie chart on the left shows us 81% of patients at the ED presenting at the ED were female. However, when we're looking at kids who die by suicide, we see that the gender disparity is flipped. By far, it's mostly boys who died by suicide in 2021. And that's because males tend to use firearms, and 90% of suicide attempts by firearm end in death. We also know from our DHS colleagues that approximately 6,500 youth were served by mobile crisis teams. This data is from 2022. The same year, approximately 1,300 stays in youth crisis stabilization facilities. And, we saw on a prior slide that a rough estimate of attempted suicides among Wisconsin youth might be much higher than what we're seeing for, for youth who are staying in a crisis stabilization facility. So we know that the demand for crisis services has outpaced the supply. We know this for sure. And lastly, I just want to say a word on 988, the Suicide and Crisis Lifeline. Though it's available to anyone and not just youth, the amount of use after 2 years of launching 988 shows the statewide demand for crisis support is increasing. And within 2 years, the Wisconsin 988 Center handled 112,000 calls, 7,200 texts. So demand is not letting up, and awareness and use of 988 is growing, which is good to know that we are building awareness and that that form of help seeking is increasing. Um, I'm sorry I had to rush through. I know I'm at time, but Karen, if we have a minute, are there any questions that I should address?
Amy, I'm going to ask you to answer them in the chat, just to
Sure
keep us
thing.
on schedule. And Andrea has been keeping her eyes on the chat. If we miss anything, please maybe direct message Amy. It's nice to
Yes.
have all the questions in the chat so everybody can see them. But anyway, Amy, as always, thank you so much for painting a picture of the real people that we're talking about. And now it is my absolute pleasure to introduce to you Beth Rudy from the Wisconsin Department of Health Services, who's going to really now dig into the youth crisis continuum in Wisconsin.
Well, good morning, everyone, and I'm absolutely honored to be here to talk about basically my favorite thing to talk about, which is youth in the crisis continuum. I'm Beth Rudy. I have been the youth crisis coordinator for the last 3.5 years for the Department of Health Services in the Division of Care and Treatment Services in the Children, Youth, and Family section. I have about, I don't even want to age myself at this point, but 25 years experience, I think, ish in youth mental health and the child welfare system. So do I go to the next slide, Karen? So today we're going to kind of take a walkthrough of the best practices according to SAMHSA, as well as how that relates to what we're doing in Wisconsin. And I want everyone to kind of keep in mind that this is, our best case scenario. This is what an ideal crisis system looks like. And we recognize at DHS that we do have some gaps in our system, and that counties and the people providing crisis services don't necessarily have the resources, the staff, the time to be putting into this ideal crisis system, but wanted to give everyone an overview of what that looks like and what the efforts we are making. I'm also really excited about the work that the Wisconsin Legislative Council is doing in terms of unnecessary EDs. They've been meeting regularly, and I think that some really great things and some good outcomes are going to come out of that meeting as well. Next. So basically, yeah, we're going to talk today about that, and then we're also going to go over the SAMHSA's best practice for the crisis continuum, which is the crisis now model, which includes someone to contact, someone to respond, and a safe place to get help. Okay, now next slide. Thank you. So in 2022, SAMHSA released their national guidelines for youth and behavioral health crisis care. According to SAMHSA, youth crisis systems should keep youth in their home and avoid out-of-home placements as much as possible. And we can do these things by really increasing our community supports. We have our youth crisis stabilization facilities, which is community-based and not an out-of-home placement. And it really matches up with what DCF is doing with their Family First initiative. We want to provide developmentally appropriate services and supports that treat youth as youth rather than expecting them to have the same needs as adults. And I say this all the time, but youth are definitely not just mini adults. They come with a whole different set of challenges and systems. They have a family system that they're working with. They aren't necessarily in control of their treatment decisions depending on their age. So it's important that we look at youth differently than we look at adults. We need to integrate family and youth peer support providers and people with lived experience in the planning, implementing, and evaluation of services. There's some counties, and I'm going to kind of call counties out by name because there's some counties doing some really great things in the state of Wisconsin, and I look to them as kind of pioneers or role models in what we should be doing. So for instance, we've got Dane County now providing parent peer specialists in their crisis continuum. We have Waukesha County, which is for a while had a parent or a peer specialist working with youth in their crisis continuum. And we just recently closed recruitment for a grant funding opportunity that will be embedding parent peer specialists in several counties in the state of Wisconsin. So we're really working towards that, having that lived experience in the crisis continuum. And then we really need to be meeting the needs of all families by providing culturally and linguistically appropriate, equity-driven services. All right, so we've got several according to SAMHSA, we've got our core principles for youth crisis systems. Again, it's really important to remember that crisis is self-defined. So what is a total crisis for somebody might not be for another. I always say I live in a family of chaos, and my status quo might be someone else's crisis. So it's really that self-defined definition of crisis. So number one, safety and security for staff and people in crisis. So that really revolves around that commitment to a no forced first approach to care. One safety issue of special concern to the youth crisis systems is seclusion, the use of seclusion and restraint. An ideal crisis system would provide comprehensive staff training on the experiences of youth placed in restraint or seclusion, trauma-informed approaches, and effective person-centered alternatives to restraint and seclusion. If seclusion and restraint occur, both the staff and the young person should be debriefed together or separately, depending on the needs of the young person. We want to employ prevention strategies to limit situations that may result in seclusion or restraint, such as individual assessments and for risk of violence and active safety planning. And I think in an ideal crisis system, and a lot of our counties are already doing this, is really coming up with those robust safety plans for youth and crisis planning for youth. And then we want to create spaces that feel safe, comfortable, comforting, and non-conforming, providing youth specific areas so that they are not exposed to adults in crisis. And when promoting 988 or other crisis response services, we want to use images and messaging that communicate a sense of physical and emotional safety. So the next core principle is trauma-informed care. An ideal crisis system, all staff in the crisis response realize that trauma is a major contributor to behavioral health crisis. They know that past trauma and community trauma impact how crisis services are perceived. Staff in the crisis response system can recognize the signs of trauma, including those that are specific to children and adolescents. And then organizations seek to resist re-traumatization of both the people they serve and their own staff or volunteer. So our significant role of peers and the peer support, including peers, can be a safe and effective mechanism for assessing and reducing suicide risk for persons in crisis. Peers can relate without judgment, can communicate hope in a time of distress, and can model the fact that improvement, success, and recovery are possible. And again, we do, I mentioned this earlier, but I think we've got some initiatives that are introducing that and bringing that to the forefront. We do have more peers probably in the adult, I don't even need to say probably. We do have more peers in the adult system working with adults, but at DHS, we recognize this, and there is communications going on that will be hopefully creating a youth peer specialist certification that will be able to work specifically with youth and better serve them in our communities. So 4 is our zero suicide, safer suicide care. Suicide prevention and treatment for youth must be developmentally appropriate, attend to critical social determinants of health, assess the presence of adverse childhood events or ACEs, and trauma, incorporate parental and guardian support, and addressed consent considerations. Addressing our recovery needs involves actively engaging youth and families in a shared decision-making process that explores the preferences and priorities, providing them with information about the supports that are available, and helping them make care-related decisions that align with their individual priorities. Staff should also support youth in identifying their strengths and natural supports, both in immediate crisis planning and in follow-up care and stabilization. And I think this is especially important when we're talking about systems of care and working within our own county, within our agencies, with the other systems caring for youth. For instance, if we're working with our wraparound partners, we're really going to embed those same things I just mentioned, that strength-based, natural supports, community-based care for those kids. And last but not least, crisis response partnerships with law enforcement, dispatch, and emergency medical services. An ideal partnership would provide crisis intervention team for youth, so the CITY trainings or similar curricula to law enforcement, establish clear policies and protocols for 911 dispatch to divert calls to the crisis response systems when appropriate to do so. If they are not co-responders, train crisis response staff on when to contact law enforcement or emergency medical services. If possible, co-locate crisis call centers and responders with 911 services, and then incorporate regular meetings between crisis response and first responders to identify and address challenges. Discussion topics should include strategies to better respond to youth, families, and youth serving agencies like schools, and using these opportunities to create shared language throughout our system as well. And I'm going to call out my partners in Chippewa County who do an amazing job of this. They have created these meetings in their county and with their law enforcement, and they are seeing great outcomes because of that. We want to provide specific trainings to responding to youth with disabilities and share aggregate data regarding youth and family crisis or calls to crisis call centers and 911. So that was a lot of information to take, and I recognize that. We're going to jump now into the Crisis Now model and what, again, an ideal system looks like, but what we're doing in Wisconsin. So 988 is an initiative that was came out, I want to say it's been 2 years now, where this is a place to call, a place to someone to contact to help with an active mental health crisis that can walk people through systems. And then we also have our county crisis call centers, which is another place for families to call. According to our 988 dashboard, and I think someone's going to put our dashboards in the chat, we saw that a really low number of 988 calls were youth ages 17 and under. This is kind of disproportionate to the mobile response numbers that Amy talked about earlier. However, if you do visit that website, you'll see there's kind of two toggles. There's the calls, and then there's the chat and text. We see a larger number of youth utilizing that chat and text feature, to me, which just signifies again that we need to meet youth where they are at. And as a mom of teenagers, I know that they really don't want to talk to me that much. They really would rather text me their concerns and chat over that way. And that's just kind of the world we're living in. So we need to meet those youth where they're at and also create our messaging around that. So mobile response. This is our someone to respond. Youth crisis services should be centered on de-escalation, stabilization within the home and community. This is an important priority for all crisis services and is especially important for youth. If it is safe for the young person and their family, every effort should be made to keep them to help them stay in their current living environment, with family or other natural supporters actively participating in the young person's care and stabilization. So really, again, utilizing our natural supports to keep kids in the home. Essential operations include responding to crisis on location and in-home and community-based settings, including schools, post-secondary institutions, recreational centers, homeless shelters, and other community centers. And we will hear from Sheboygan County soon, but I'm going to call them out because they are providing an amazing school-based crisis response where they've got responders right in the school. Again, meeting those kids right where they're at and where those crises often occur. We need to be available to quickly respond quickly to crisis. Arriving on site within 1 hour of dispatch is the general standard. We also recognize that in our more rural counties, that can be difficult based on staffing and based on geographical location. Second, staffing and training. Ideal systems would have access to licensed or credentialed clinicians in a supervisory role who has expertise and experience using evidence-based assessment tools with youth and populations. The clinician may be on site or may consult over the phone. We want to incorporate youth and family peers within our response teams, respond without law enforcement accompaniment unless special circumstances warrant their inclusion. Safe reduction of unnecessary police involvement is critical for youth of color who may be more likely, who are more likely than their white peers to face harsher consequences stemming from police involvement. And then provide staff training on how to describe mobile response services to youth, their caregivers, and other callers. Sometimes it's just that education piece, making sure that people are aware of the services out there and available. This entire approach should be framed in terms of acceptance and help, never blaming the youth and their families. In terms of on-site needs, mobile response teams may use a standardized screening and assessment tool to help promote shared understanding across providers. Those tools include the CAT, the Crisis Assessment Tool, our CANS, our Child and Adolescent Needs and Strengths, the Child and Adolescent Service Intensity Instrument, and then our Columbia Suicide Rating Scale. In terms of our de-escalation strategies are intended to increase safety. Oh, did someone say something? Nope. Just kidding. Sorry, I thought I heard something. To increase safety while decreasing emotional distress. Sometimes that requires helping families to recognize their own behavior in that moment, because it can be difficult for a young person to be calm if their family member is at a heightened emotional state. So in terms of this, oftentimes we're using our DBT skills. And again, I'm going to call out Chippewa County. Chippewa County has actually implemented DBT in their school districts, and they're training teachers on DBT skills so that they can help de-escalate those crises right in the moment in the school. Some examples of that, I know I'm running out of time, are projecting a calm, empathetic demeanor, decreasing stimulation, taking movement breaks, journaling, sensory soothing, all of those DBT skills. So on-site needs in terms of safety planning, creating a crisis or suicide safety plan is a key component of ensuring the young person's short-term safety and long-term stability. This should be a collaborative and strengths-based process that identifies and integrates their natural supports. I want to call out my Waukesha partners. Their peer support specialist has implemented really youth-friendly crisis response tools, and I can definitely give their contact information, or at least the tools that I have been given to share out, because I think they're great tools that are really that kind of meeting youth where they're at. And then care coordination and follow-up. Mobile response teams may coordinate a transition to community-based mental health services and crisis receiving and stabilization services. Our crisis workers need to know the crisis and medical facilities in the region, and also the broader array of child and adolescent supports and services that are available to them, and really provide that warm handoff them to crisis stabilization facilities and providers. Okay, and our safe place to get help. Ideally, we're looking at in-home stabilization for this. That serves as a bridge that helps youth transition from immediate crisis services to ongoing care in the community. That may be provided by a therapist or clinician in partnership with a professional or a paraprofessional who can help the youth and families implement the plan that identify with their therapist. Sample in-home services include assessment, parent education programs, peer supports, coping and conflict management skills, skill building, and behavior management training, and offer those warm handoffs. And since I know I'm over time, I'm going to quickly jump into our YCSFs. So One of our YCSS is presenting later. I do not want to steal their thunder, but we currently have 3 open YCSFs in our state. We have our 8-bed facility at North Central Healthcare, which is located in Wausau, Wisconsin. Those facilities serve youth ages 17 and under, both male and female, in an 8-bed facility. We have our Masana Center, which is in Milwaukee at Lad Lake. That is a 6-bed facility serving female youth. And then I will let the Mott Center talk about all of the great services they provide. But keeping in mind in terms of our YCSF that these are a voluntary service. It is not an out-of-home placement, so it does not require a 48 or 938, but also cannot be utilized as that out-of-home placement, and rather crisis stabilization, short-term and voluntary. So I think we've got 21 messages in the chat, so I will make sure to read those through and let the rest of the day continue, but I really appreciate everyone's time.
Awesome, Beth, we can't thank you enough. Thank you. And I think it just, the content, I mean, you have a lot to say, and we gave you a rather unrealistic assignment, but thank you for giving us the information you did, the highlights. Please lay your eyes on the chat. I encourage people to go to Beth's breakout room if you want to know more from her, because you'll have opportunity to learn more from her. So now I want to make a transition to lived experience, because if you know our office, you know lived experience is everything for us. So I'm going to turn it over to Andrea Turtenwall right now, who will introduce us to a couple of wonderful people and their stories.
Thanks, Karen. And I also want to just provide thank you to Amy for setting the context for how frequently crisis situations emerge in Wisconsin, and how many young people are feeling anxious, depressed, and suicidal, which means they could have a crisis at any moment. And for Beth walking us through what should happen in those situations, and just really overtly recognizing that's not always what happens when families are going through crisis. And so really our next step here is to hear from 2 stories as told by the parents of children's mental health crises and what happened. And we'll consider how their experiences align with what DHS's core principles are, but also how they divert, and just like recognizing the best case scenario isn't always what happens. And so first we're going to hear from Michelle, and it's a pre-recorded video because she was feeling a little nervous about presenting to all of you. She lives in Milwaukee, and we'll hear about one particularly challenging day for her middle school son. And before we hit play, I just want to offer that this is a pretty intense story, so I encourage you to use your coping skills as you need as we listen to these stories. So with that, why don't we hit play, Karen, and go from there.
Two and a half years ago, my son was in 4th grade, and I had been getting phone calls very often about like his behavior at school. And this one particular day, I got a phone call. The school told me that my son, his behavior was pretty severe, and they don't really know what triggered him, but they said he was running around the school, physically attacking other children, teachers, and staff. He was like growling at them, swinging at them to punch them, biting, and just completely out of control. And he was not really responding to their attempts to calm him down. And he had completely went around destroying property as well. And I know he went into the principal's office, attacked the principal, tore up her office, and he actually like told her he was the devil. And he took 2 sharp pencils and he put it to his neck like he was going to stab each side of his neck. That's when they called me, and they told me I needed to get there immediately. And this school happened to be right across the street from a police station. Um, no police were called. I drove him to the clinic where he was receiving therapy, hoping that his therapist was there. His therapist was not there, but there were other staff, other therapists, receptionists that could clearly see the kind of crisis we were having. And several of them, kind of grouped around him to try to talk to him. And the same thing happened there. He was lashing out at everybody. He was destroying their property. And one therapist decided she was going to pull out a crucifix and start doing an exorcism. And I just, I couldn't believe it. And somebody else called the police. So they got there pretty quickly. He was there for about a week and a half. When I went to pick him up, he seemed confused, like he didn't know who I was, and I wasn't sure he was ready to come home. But anyway, they discharged him. One of the referral cards I saw that the hospital sent home with me in the discharge paperwork was services for wraparound. This is really was key at the time for him getting some ongoing support for his mental health. And it continues to be a really strong support system for us. They provide what's called a crisis stabilizer. And usually they tell you, the hours they're available, but they are available for your child to talk to, before police are called or before transporting to a hospital. They attempt to, sometimes come to your home and see if they can get them to calm down or talk to them over the phone to see if they could maybe distract and use some coping skills. So with calling the police, the problems that I came across is they are really kind of impatient when it comes to mental health, because like we had the same police officer come to our house probably about 4 or 5 times. And on the last time he came, he told my son, if I have to show up here one more time, I'm going to take you away from your mother. To this day, my son has not gone there where he's threatened me with a knife or any cause to call the police. That absolutely terrified him. But our main support now would be wraparound services, because it eliminates the need for even calling the police in most situations when it comes to mental health, and eliminating the need for the hospital visit most of the time.
Thanks for playing that, Karen. And just want to take a pause because that is a heavy video. And so first, I'd like to say that, again, some of the things I heard from her story, and I'd invite you all, if you have reflections in the chat, to feel free to add them. That again, sometimes the parents don't know what to do. Like, parents are experts, and sometimes it's like, I'm not even sure how to solve this situation right now. And also just how wraparound services have really served that family well. And again, police involvement. It is not an ideal way of crisis systems working, but often that's the common thread between mental health crises and the lived experiences that folks have. So just for context, again, too, the story is not over at all. Their kind of most recent challenge was that the school said, he's got to go. You got to send him to another school. And so, of course, there's like the challenge of like identifying a school that will provide the right supports, and also the transition and the stress of all of that. So I just want to be clear too, like this is an ongoing life story that we just had a peek into. But I would invite us to share some love in the chat for Michelle, because like I said, she was really nervous to present. And so I'd love to share after with her, like, hey, here's all the positivity and the messages that folks like, appreciation for her being so vulnerable and sharing a really hard moment for her family. And with that vulnerability, I also want to welcome Rob, who has been in our network for so long, and was also willing to, be vulnerable and share some of the stories of his family with us all to, again, set context and provide clarity. So, hi, Rob. Do you want to introduce yourself
Hi.
and tell a little more about the couple of stories you have for us today?
Absolutely, and hopefully everybody can hear me.
Yep.
I just want to say thank you very much, Michelle. That was a very powerful, and I totally understand the vulnerability. It is scary for us as parents to be able to tell our story, because we're always worried about how it's received. Here it's a safe area, Michelle. It was received, and I have to. They want to do an exorcism on my daughter too. So there's just I don't know why that
That
comes
brings up a
but
lot of feelings like that. Yeah, that
it does. It's just kind of like, no, that's not what we need right now.
yeah.
But thank you, Michelle, for your story. So yes, my daughter is I should introduce myself. I'm Robert Kaminsky. I'm a lived experience parent partner with the Office of Children's Mental Health. Have been here since day one with the Office of Children's Mental Health. It is awesome to see that we're still going strong. I'm up here in Outagamie County. I'm a certified parent peer specialist. I also work with a lot of the other committees that are out there, and deeply involved with our county wherever we can. But they asked me to share about an experience that we had, actually a couple of experiences we've had with our daughter Zoe. She's a great kid, there's no doubt about it. And the first story I'm going to experience is the fact that she did everything right, but the system failed around her. I mean, she came to us at night and said, hey, I'm getting bullied at school. I've gone to the administrators, I've talked to the teachers. It seems like they're not listening. So we set up a meeting. We went in and we talked with the administrators, we talked with the schools, and just got like, hey, this is, she's doing the right thing. But she feels like she's not being heard. And she came back to us and just kind of, it's still continuing. And I had a meeting just with the principal and with the officer, the SRO officer at the school, to talk about this, because I knew that it's going to come to an head. And I know my daughter, she's going to reach a certain level, then she's going to just let it go. And she's going to just explode upon everything. And some of the things we discussed is with the SRO officer is, with my daughter's background with her biological family, don't try to put her into a squad car. Because there was one time that she went into a squad car and she never saw her family again. She went to an orphanage, and then this family halfway across the world came and took her out. We adopted her, which in itself is very traumatic. So that police car really means that I'm going to lose my family. Nothing happened. She exploded. She took things into her own hands, took care of the situation on her own, and it didn't go well. As you can imagine, in middle school, the way that they would take care of a situation.
Oh,
So
yeah.
by the time I got to school, what I saw was a lot of squad cars. And as I was walking to the school, I heard my daughter in the back of one of the squad cars. So I know where my daughter is, and I know what she needs. And I hopped into the backseat of that squad car. It wasn't too long before I was ordered out of the squad car. I could not be in there with my daughter. They had questions for me. I'm doing what my daughter needs.
Right.
and I was ordered to leave my daughter. At that point, my daughter also came out of the squad car behind me. And what I witnessed was 3 grown men wrestling with my daughter on the ground, using a lot of the same words that she heard from her childhood, coming from a family situation, biological family situation, where one predator lived in the household, and another predator was their safe household to go to when dad was not doing so well in the family. And I really made a connection with the words that they were trying to use to calm her down were actually making things worse.
Mm.
And she wasn't resisting arrest. She's at this point fighting for her life. And she was so far in that moment of trauma that she could not even understand or speak English anymore. We had to go
And she's
back
a
to her
middle
birth
schooler.
language.
Let's keep remembering that. Like, this is a little human.
Right? Right? And it was just very traumatic to me. I mean, seeing that as a parent, it just it tore me apart, and it led me down this path to where I am today. That was a defining moment to where me as a business owner, as a licensed plumber, decided that I need to get involved within mental health. And it brings me to this point where I am now. The whole system broke down. I mean, it could have been totally avoided. It could have been handled in a completely different way. Um, but out of that, that's one of the things that we always try to focus upon in our family is what good can we come out of it? And what did come out of it after I calmed down, took 2 or 3 weeks for me to become rational again, is that we really pushed for CIT training with the police officers within the school. This was a defining moment for the school too. It was a moment that the school realized that there's just got to be a different way of doing things.
Yes.
And my daughter's doing great, but it really did affect her. It set us back at that time years in therapy.
And just one incident, just like one day, 1 hour, or however long that was, that has these massive ripple effects.
Correct. And it was on the whole family.
Right?
She's got 4 other siblings that we have in our household, and it affected the whole family. When my son was signing up, I mean, she's in middle school. A year later, my oldest son, is signing up for high school classes, and the principal saw his last name and asked him if he had a sister by the name of Zoe, which for him was just kind of like, I'm not defined by my sister. But that action had gone all the way up to the high school. The high schools already knew about her, and the administration in the high school already knew about her. She was still in middle school.
Yeah. Well, I appreciate you sharing that story. I'm not sure we have a few minutes if you want to share the second story of just that crisis
I'll go into it real quick.
intervention.
I'll
Yeah.
go into it real quick. So
Yeah.
I'm going to fast forward. We have helped Zoe get to a point where she's able to go to the tech outside of high school. She's able to go to the Fox Valley Technical College. She had a day that she was struggling. She hit the hope line. She started texting them. She's got a lot of suicidal thoughts. She actually attempted suicide while she was at the tech. They couldn't locate her. Literally, fast forward. We had a meeting with the tech college after everything had happened. We was able to find her. They found her in a bathroom. But talking to the administration there at the technical college, they practice for fires. They practice for tornadoes. They practice for armed assailants. They've never thought about practicing for how do you locate somebody who's attempted or is thinking about suicide within your walls.
Yeah. What's the system
Never thought
response
about
when that's happening? Wow.
Right. And because they weren't ready for it, they were descended upon by fire, police, everybody going room to room searching.
Oh, geez.
And their own security didn't even know what was going on.
Do you know if any changes happened after that? Like, again, I was hearing from your earlier story, some CIT training happened. Like, did Fox Valley Tech figure things out, or, you know, are there any ripple effects from that experience?
From what I've been told is, yes, they have looked at training, and they've also looked at the fact that if you're attempting suicide or if you're doing self-harm, typically you're going to do it in a quiet area. So to be very mindful of who's in those quiet areas.
That's a good point. And
And
where to look first, because I remember, again, in the longer part of your story, they went through lots of places, including your house. And it was like, she's not here,
right,
she's not here. This is
right,
critical.
yeah,
You
yeah.
got to
They
find
showed up at
her.
our house first to begin with, because they didn't know where she
Yeah.
was. And there again, that's the importance of parents. We did know where she was, but
Yeah.
nobody takes the time to pick up the phone. Nobody tends to think about parents and how involved we possibly are with our own kids.
Right. Well, I really appreciate you sharing both of these stories to again, just provide more context of what the children's mental health crisis system can look and feel like for real life families in the state. And so we'll have a breakout room later today. So if you'd like to talk more with us, feel free. But for now, I believe we are going to be heading into a break. So I'll pass it to Karen to officially do that. But again, send some love for Rob in the chat. Thank you so much for being with us and for whole 10 years. Thank you.
Yeah. Yes, thank you so much, Rob, and Andrea. Thank you too for helping guide the conversation and keeping us always focused on lived experience. We're taking a 5-minute break now. We are exactly on schedule, and I will see you all back here promptly at 11 for when we're going to hear from our 2 counties.
Were observing and they were observing and seeing some things going on with these youth that maybe indicated some struggles in the family and at home, and they felt like they really weren't able to access any support for them until things reached the level where they're getting involved in either CPS or youth justice types of situations. And they were really struggling with that reality and coming to the county asking, you know, what we could be doing to help with that. Internally, we were also having some of those same struggles, figuring out how do we work with the entire family systems. You know, we have maybe one member of the family that we're getting involved with, but the way the systems are set up, it doesn't really allow us what we really need to impact that entire family unit and be able to move some changes forward. And then obviously everybody still to this day is having issues with, you know, just the concerns about wait lists and how long it was taking. Even if there were services out there, they weren't immediately accessible and things were continuing to go downhill for these youth and their entire family unit in some cases, trying to get into the services that were actually out there, but not technically available at the time they were in need. So we had a lot of meetings with the school districts, and we decided to roll out what we now have as our CAT team. The initial reaction we received from the schools was some hesitancy, some concern that maybe it wasn't going to really meet the need that they were hoping for. We did come to an agreement that We did have to start somewhere, and we were going to start with, how we had this program laid out, and then certainly be willing to continue the conversations and make any adjustments or changes to the program as we went on. We started this program in February of 2019. And through that first year, we had received 47 families that were referred in to work with us. So we define the consumer as the youth, but like I said, we do spend a significant amount of time with that entire family unit. And the family unit is variable based on each family. So it's going to be really anybody that either lives in that home or is a significant part of that child's daily life. So, if they go home from school at 3 o'clock and they're going to, a grandparent's home until, 8 or 9 that night, we're also going to be pulling in those grandparents to work with them as well, just to, like I said, look at that entire unit and figure out what we can do. Again, with the main effort being keeping them out of the more involuntary types of services. So out of the hospital, not having to go into CPS, youth justice, and preferably not having to have services with the county at all. That we could get this CAT team in there soon enough, do some early intervention, and get them referred into typical community type of resources instead of the county being involved, if at all possible. So we utilize crisis billing for a decent chunk of the amount of work that we're doing with these families. So we really lean into the crisis linkage and follow-up billable portion of the crisis program. So when you're looking at the criteria of what falls into crisis linkage, the areas that we are really focusing on is reducing the risk of a worsening crisis. We're looking at reducing the level of risk of physical harm to the member or to others. A lot of times there is some form of aggression going on in these homes, whether that's throwing objects at a wall or whether that's actually physical between any members of that household. And then also the last thing that we lean into with the specific crisis linkage piece is resolving or managing family crisis to prevent out-of-home placements of the children, improve the family's coping skills, assist the family in using or obtaining mental health or other supportive services. So those are the 3 categories under crisis linkage that we are utilizing. And then if we move into the follow-up side of things, we're leaning into providing evaluations, referral options, and other informations to the consumer or others involved with that consumer. We're coordinating the resources needed to respond. We're resolving or managing family crises, again, to prevent that out-of-home placement, improve the coping skills, help with ongoing mental health or other supportive services. And then the big one in this area is providing follow-up contacts until the member has begun to receive assistance from an ongoing service provider, unless they do not consent, obviously, to that further. This is an absolutely 100% voluntary program for all of our families. So our current model, we initially started with one team, which had 2 staff. So we work in teams of 2. So we had a team of 2 that one was a licensed therapist and one was a master's prepared behavioral health worker. We eventually dropped the requirement of one of them being licensed. Our initial thought was that we would be doing some short-term therapy with them as well and wanted that licensed person for that piece. And the reality was it's not so much true therapy that's happening, in all honesty. It really is that crisis management. And with the job market being what it was, finding licensed people to do this kind of work was really difficult. And so in looking at that, we realized we didn't necessarily need that piece. So we bump that down to just a master's degree required, because we did want to make sure that they had a good foundation. This is not work that would be easy for somebody coming fresh out of school with a bachelor's degree that really hasn't done much work in the field. This is pretty high need, pretty intense levels of support that's being offered. So we wanted that, stronger background. The team of two attends almost every meeting together. It is not uncommon that, throughout these family meetings, there might get some tensions might rise. There might be, sometimes the adults, sometimes the youth that, walks away out of the room. There's sometimes needs to separate and divide and conquer and bring the group back together once more level heads are prevailing. So that team is really instrumental in being able to do some of that, mitigation that happens during some of these family sessions that are taking place. We currently, as of this year, as of 2024, had grown large enough, and our wait for this program was even getting to be longer than we felt comfortable with. So we now have a second team as well. So we now have two teams of two staff that are going out, and each team is working with approximately 30 to 40 families. So it's a pretty intensive program that these two teams are keeping up with. Our referrals are coming from the schools. They have come around and do appreciate the program. I would say the main thing that changed from the way we had initially designed it, I talked about our staffing requirements, but in addition to that, the amount of time that we thought we would be spending with these families, we had really intended for it to be a pretty short-term program, but it's gotten to be, I would call it more of a medium-term type of program, again, just because of the wait lists to get places. We do not feel comfortable saying, okay, now you've been referred, see you later, good luck. We are staying involved with these families until they have started those services. This team also follows up and works with any of the youth that we have that are waiting to get opened up to CCS. We were seeing that a large amount of our youth Winnebago admissions were these families who were waiting to get opened up in CCS. So we started having our CAT team work with them, and that has in the last 18 months, none of those kids waiting have been in Winnebago. So the CAT team stepping up and working with these families has really helped with that. They also connect with any youth that have contact with our mobile crisis team. So they find out the next business day that there has been a contact. They reach out to those families. They provide them any support they might need. Some of them do take that invitation and decide to work with the CAT team. Some we just do a little bit of follow-up for a while, and then they go off on their own. And then they also monitor any commitments for the youth if they don't already have a provider within our county system. That CAT team would monitor those youth. Some of them also opt into the CAT program. Some of them do not, and that's fine as well. We also get referrals from law enforcement, from CPS, our youth justice system as well. And then we're getting a handful of self-referrals as well. So individuals that hear about, their neighbors working with this program, or a friend of theirs is utilizing CAT and they feel like it would be beneficial for their family as well. So we love to get those referrals in there too. So we are getting some self-referrals. Once we have the family connected to a longer term service, whether that's like a CCS program or whether that's a community therapist, we then step out and back out of that family, but we do follow-ups with them at the 30, 60, and 90-day points, just to make sure that connection with that new program or provider is working well for them. Do they need anything else in the meantime? And then if at that 90-day point things seem to be moving in the right direction from them, then we do fully close them out of our CAT program. So as of the end of September, We are about 5 years in, and we have had 375-ish referrals at this point. Not every family agrees to the program, but the high majority of them do come in for the service. We are working very closely with our own county youth justice and CPS programs, as well as the referral base with our CCS youth program. And we work pretty closely as well with in-school therapists that we have in our county. It's called the PATH program in our county. But we've developed a close relationship with them as well, because they note that while they can do some work with that student in the schools, they're really missing that piece of connecting it back to the parents in the home. So we have that ability to work with that PATH therapist, understand what's being talked about in those therapy sessions, and then bring that back into the family meetings and make sure that that plan and the things being talked about with the student are also being worked on and shared with the family. So we track a number of different pieces of data. We are working with our own like epidemiologist, basically our statistician here at the county, to figure out how to best use some of that data. So we are hoping to have a lot more stats that we can present on down in the future. What I can say that we do know for now is looking at the families that we have in our program. Before they started with our CAT team, they were averaging 4.5 referrals per year into the CPS or the youth justice program. Not necessarily all new cases being active, but they were being referred in on average 4.5 times a year. Once these same families completed their work with the CAT program, that dropped to 0.8 referrals in a year. So a pretty significant shift in what's happening with those, like I said, those more involuntary programs between that and then the change we've seen at those Winnebago admissions. So we're really happy with how that's going. We are going to continue, obviously, tracking. There's a million data pieces I'm curious about that we're going to try to continue to build on and figure out how to report out on. But that is our CAT team here in Sheboygan.
Awesome. Great. Jackie, thank you so much for joining us today. And as I've mentioned throughout the meeting, Jackie and Kim are going to hold a breakout room too. So bring your questions ready for them in that breakout session. And I wish I had 10 minutes just to ask you questions, because I have lots of them, and I just applaud your county and your leadership support there. And likewise, I would do the same applauding for Jefferson County. So right now it's my pleasure to turn it over to Kim.
Hello. Do we have my PowerPoint?
We do. Can you see it?
No, I see Sheboygan County.
Ooh, what? Okay, let me stop sharing and start again. Okay.
Okay.
Do you see it?
Yep.
Awesome.
So first I want to start with really thanking the two parents that shared their lived experience, and telling a little bit about myself. I am the crisis manager and the adult protective supervisor for Jefferson County Human Services. I have been with Jefferson County for 27 years. I have pretty much worked in almost all of our behavioral health programs. So I ran our crisis stabilization facility. I worked in CSP, community support program. I worked in CCS and supervised CCS. I have been in crisis, working and supervising in crisis for probably the past 12 years. I am also a parent to 7 children, 6 of whom are adopted, 2 internationally, and 4 from foster care. So I come not only as the perspective of a professional, but as a parent who is raising children who have trauma and mental health concerns. And that really drives me to try to provide the best services possible to children and families, and we are all human, and I know that myself and our team are not perfect, but we do try to learn from each situation. So our team mission is really to provide preventive services and resources to the individuals in the county that are experiencing or may experience a crisis. It is also our mission to always provide the least restrictive services to an individual. The team believes individuals will get better in supportive environments and when they are part of a plan. Next slide. Next one. So our agency was certified under HS 34 to provide emergency mental health crisis services in October of 2007. At the start of this, we had 5 total crisis staff. So we had 3 staff that covered all of the overnight and weekends. And then we had 2 staff that covered 7 a.m. to 5:30 p.m. And that should say Monday through Friday. They would love it if they saw the Monday through Thursday. Today we have myself as the crisis manager. This summer, we were able to add a crisis supervisor to help me with supervising the staff. And we continue to have our 3 after-hours staff who cover overnights, weekends, holidays. They not only do crisis, they also cover child protective services and youth justice for those after hours. We have 2 daytime staff that are at the agency answering those phones and going mobile from 7 a.m. to 5:30 p.m. And then we have 4 staff who are housed with our different law enforcement municipalities. So they actually have an office at the police station where they can go out in real time when there is a crisis and law enforcement are getting called. Of the 4 embedded staff, they cover some daytime hours, some evening hours, and weekend hours. We have coverage at our agency 24/7, 365 days per year. The staff not only answer the crisis line, but they are able to go mobile any time of the day or night, wherever the situation is occurring. We do not contract out any of our crisis services except with our youth stabilization facility. So we have been a part of the Children's Crisis Intervention Grant since the start of it, which time is a thief and goes very fast when you've been here for so long. So it's been many, many years. We have utilized this grant funding to send at least 5 staff to the Crisis Intervention Conference each year. We have paid for multiple therapists to attend the intensive dialectical behavioral therapy training. We really focus on evidence-based practices here. We also have therapists who are trained in the DBTC, so dialectical behavior therapy specifically for children. We started with in-home crisis stabilization and being able to really utilize that more. So youth and younger children could stay in their home with their family and more support could be offered. We also purchased coping curriculum, which covers youth ages 7 to 13, and the CAT project, which is for ages 14 to 17. And that's a cognitive behavioral treatment for children with anxiety. It has 4 components. So recognizing and understanding emotional and physical reactions, clarifying thoughts and feelings, developing plans for effective coping, and evaluating performance and giving self-reinforcement. So our DBT curriculum, like the DBT skills and the coping CAT, are written into crisis plans for the youth that are in services with us. And we have integrated plans, which includes What does maybe the caregiver need when this youth is in crisis? What support can we give them? And how can we help them when, either it's, their child or somebody they're guardian of, or maybe it's a foster parent with a foster child. How can we support whoever else is in that home when this youth is in crisis? What's going to be helpful to them? So that's all part of our crisis planning. We recently opened our youth crisis stabilization facility in January of 2024. We typically serve youth 10 to 17 across the gender spectrum. A typical stay is 3 to 5 days. It can be up to 30 days if they are meeting criteria and are engaging in those services provided. Again, our youth crisis stabilization facility provides DBT skills to youth and other coping skills. They provide therapy. They keep their team involved in their treatment. And more importantly, the therapists and staff there involve the family. They'll have family meetings, family sessions to help with that transition back home and into the community. For youth who are in our county that go there and maybe they don't have services, that's a time where our crisis team then will get the youth and family connected to services so that when they're coming out of the stabilization facility, at least they're in services or in the process of getting services. Our outpatient clinic does have what's called open access. So each day we have slots where people can walk in and immediately get engaged in therapy services with our outpatient clinic. So our protocol is if we receive a call from the person, family support, school, emergency room, police department, we gather the basic information over the phone, and that determines if an assessment is needed. If so, we go to wherever the person is. For youth and younger children, we will contact the parents. We'll make sure that they are aware that we have been called if it's from a school or other entity, because we want them involved. We assess the person. Our crisis staff never make decisions alone. So they're either calling myself, the crisis supervisor, the after hours behavioral health person who's on call, or our medical director to staff the assessment and how we're going to move forward. If it is determined an emergency detention is appropriate or needed, our staff is certified as juvenile intake workers, so they write the emergency detention statements and sign them. Our law enforcement does not. And we also locate the facility. People have mentioned CIT training. It just so happens that I'm also a CIT coordinator. And currently this week, I've been co-facilitating CIT. We involve people with lived experience, parents who children have experienced mental health concerns and have had contact with law enforcement. And we also have a program here at Jefferson County called Parents Supporting Parents. So these are parents who have been involved with our child welfare system, who have had either mental health or substance use. And they also come and talk to our law enforcement during our week-long CIT so that they can understand and really hear from people who have experienced these and what might have been more helpful or what was helpful. So outcomes, we track multiple items each year. The one thing that I am very proud of is that in 2020, we had 0 youth detained to Winnebago Mental Health Institute. So we did not do an emergency detention, sending any youth to Winnebago. We also had a 90% diversion rate in 2022, or in 2020. Then in 2022, any return to more restrictives on youth that are already on a mental health commitment. We returned 0 youth to Winnebago. Our diversion rate that year was 85%. At this time, youth were coming back into school after COVID. And we were getting a lot more calls from schools about children being depressed and anxious. And I think we're still seeing the effects of that, where kids were at home and online for school, and now they're back in fully in the school. We also see how social media plays a part, bullying that can be done, things like that. And as I said, we opened our youth crisis stabilization facility this year. We've been able to divert youth there instead of hospitalization. It's also been used to preserve foster home placements and assist youth in learning skills. The other thing I wanted to comment on is through other grant funding, we several years, I don't know, maybe between 5 and 7 years ago, we were able to bring in the Mazas who wrote curriculum DBT in schools. And we invited all of our schools that serve Jefferson County youth to be trained in DBT in schools. And then we also have satellite offices for our outpatient clinic in several of the schools within our county. And so those therapists who are there can see kids in real time. They're also duly trained under 34. So they are able to do crisis assessments, and they have helped the staff at the schools become self-sustaining in offering the DBT schools curriculum to students, usually in health classes or in other classes. So I really appreciate everyone's time. There's so much more I could talk about, but this is my contact information. If you can't make it to the breakout session, or if there's more things that you would want to talk about, feel free to reach out to me. Thank you all.
Awesome. Great. Thank you, Kim, so much. And I have a whole list of questions for you too, but I'm not going to ask them now because now is our time for people to engage more with the presenters we had. So we're giving you the option to pick the room you want to go into. Room 1 will be crisis system with Beth Rudy. And then we've got an OCMH support in there, Kim Ethan. Lived experience will be Rob Kaminsky with Andrea Turtenwall. And then our county programs are going to be the 2 fine people we just heard from, Kim Prop and Jacqueline Mogileski. And Amy Marsman will be in that room. So I'm going to open up the breakout rooms right now, select the room that you want. And if you have any difficulties, just hang in the main session and I'll just slide you into a room. And we'll chat for 15 minutes.
Karen, this is Terry Enters. I missed how to get into it. I clicked on the button. Could I go to 3, please?
Sure, you bet. Let me find
Thank you.
you, Terry. Okay, room 3, here you go.
Karen, I also missed clicking. I wanted to go to 1. This is Phyllis.
Great. And who
Thank
is
you.
that?
Phyllis.
Phyllis, gotcha. You want to go into 1. Okay.
Hey, this is Melissa. Could I go to 3, please?
You got it.
Thanks.
Karen, I missed the rooms too. 1, 2,
Sure.
3 was.
Yes, room 1 is the crisis system, so Beth Rudy. Room 2 is lived experience, and room 3 are our county presenters.
Ooh, could I do 1, please?
You got it.
Thank you.